Dr. Feldstein, you can start.
Okay, well, thank you and welcome everybody. Good evening and I guess good afternoon, depending where you are in the United States. This is our fourth in a series of house calls on common and not so common pediatric neurosurgical conditions. It's primarily designed for patients, parents, families, children. But that said, we've seen many physicians have also logged on. If the questions or the material seems too easy, I apologize. I want to make it reasonable for a general audience. Certainly, there's an opportunity at the end to ask questions of any level. So I hope we can keep everyone interested in the topic and we'll try to move along. I think it's set aside for an hour. I'm hoping it's much shorter. I was once told a good talk ends on time, but a great talk ends early. And I'm hoping this is a spectacular talk. But the most important thing is I think to have time for questions and answers at the end. And we'll talk more about the team a little later, but this is the four of us dressed up to the nines, or at least as best as I can ever get dressed up, as you can see right now. So with that, we'll move into today's topic, which is on Moyamoya. Also called puff of smoke. And definition, it's a vasculopathy, meaning it affects blood vessels. Not clear why, but primarily of the internal vascular supply to the brain, mostly the internal carotid arteries, but occasionally vertebral and basilar arteries are affected. Puff of smoke is a term that goes back decades, and it's used to denote the overall radiographic appearance of the blood vessels that are being established to try to augment the failing blood supply to the brain. So the term puff of smoke has come to be synonymous with the condition of Moyamoya. It can be either a primary condition or secondary to other causes, which we'll get into. It can be unilateral presentation, it could be bilateral presentation, and it could also progress. And certainly I've seen children who've had it unilateral and years or even decades later, it's progressed to become bilateral. So primary Moyamoya is that which is not related to other conditions or risk factors. The term is a Japanese term, probably because it was really, I think, appreciated, recognized in that population. And so they essentially coined the term. It's a term that's used worldwide, and in no way is it isolated to Asia. We see it throughout the world, throughout the United States. The Moyamoya syndrome, which I see probably more of than Moyamoya as a primary condition, is associated with many conditions such as, this is not exclusive, but these are certainly the most common: sickle cell disease, Down syndrome, neurofibromatosis, radiation exposure, and by this, generally it's radiation to the brain, usually targeted at the base of the skull where the internal carotid arteries are coming up, so tumors that are near the optic chiasm, pituitary, or the classic ones, and rare cases of infection, fungal basilar meningitis has also been associated with it. I probably see mostly sickle cell disease owing to the patient population in my area of the city and at my hospital. It may be as high as 30 to 50% of my population have sickle cell disease. Why is it relevant? Well, clearly if you have a subgroup of children, in my case, who I treat, who are at risk, they need to be screened a little more closely if they're in that population or any of these groups. Children and adults do present differently. It's not necessarily clear why. In children, it's usually one of these three things: ischemia, seizures, or headaches. Certainly, you'd want it to be a reversible problem when it first presents. So either TIA, which stands for a transient ischemic attack, which is a temporary loss of some function, be it motor or sensory, that responds over time or just spontaneously corrects. Hopefully it does not present with a fulminant and irreversible stroke, but it can. Seizures may be the heralding sign of Moyamoya. And finally, again, not so clear, headaches. And it's interesting because the headaches in fact, are sometimes the hardest things to respond, even with appropriate therapy. So you may have corrected the problem of blood supply, but still have headaches. Adults, while they can present with the same symptoms, often present initially with hemorrhage and sometimes catastrophic hemorrhage owing to the location of these abnormal blood vessels. Even before diagnostic studies, you have to have at least the thought that you're dealing with moyamoya. For headaches, it probably would not be a very common assumption, unless, of course, you had one of those risk factors I mentioned. But anyone who has a new onset of seizures, stroke, TIA, certainly it comes up. And diagnostic studies, generally speaking, people would start with CAT scans, MRI scans, and then based on those findings may then go on to CTA, which is CAT scan angiography, MRA, which is MR angiography, and very lastly, cerebral angiography. And there are many neurosurgeons who will not even use cerebral angiography for reasons we'll get to a little later, and rely primarily on the CT and MR variations of the studies. But I still think there's a role for cerebral angiography. This is a sort of a classic finding, and I must say, of the hundreds of children I've seen, it's hard to find these classic findings on MR. So when I see them, I try to save these photographs. The picture on the left, I'm not sure if my arrow is working, is pointing to some very dark gray, almost black spots that you can see right in the middle. Those are the, quote, puff of smoke. Those are the new abnormal, very weak-walled blood vessels that are being created spontaneously by the body in an attempt to bring new blood supply to basically an oxygen-starved brain. They are the picture that has led to the term moyamoya, or puff of smoke. It's easier to see on this projection on my right of the screen, which is what we call an AP projection. We're looking straight at the brain, and I jumped ahead, but it's fine. The vessels are, again, they're the new blood supply to the brain. They're not normal blood vessels. While they're there, they should be invisible on these studies, but they're dilating up in an attempt to bring oxygen to the brain. The brain is starved. If it can get oxygen anyway, it will attempt to do that, either through these deep vessels in the brain or through surface vessels in the scalp that'll actually permeate through the skull, through the membranes, over the brain, down into the brain spontaneously. In fact, there are cases of people who spontaneously correct their deficit by developing these huge collaterals, either deep from the brain or from the surface, and may actually avoid the need for treatment, but you can't predict who's going to be in that group, and most don't achieve that, and most become symptomatic way before. The picture on the left shows you the MRA, and this void, I'll show you, this is the carotid artery coming up where my arrow is showing it, coming out towards what we call the middle cerebral artery, which is really the main blood supply to the motor and sensory cortex of the brain. And you can see a block there, or I should say just no flow, relatively speaking. And the equivalent angiogram, this is the same patient, is on the right. And it shows the same lack of caliber of that middle cerebral artery. It shows all of these new vessels that have sprouted up, an attempt to get flow out laterally to where there's diminution of flow. I still like doing these angiograms for a couple of reasons. Even though the MRA shows the blockage here, or the decreased caliber, I have had cases where it's an artificial finding for some reason. It's a technical issue in the way MRIs are done and MRAs are done. And I've done angiograms only to find normal blood flow, even though the MRA suggests it's not there. I suspect the CTA would not do that, but we have shied away from CTA just from issues of radiation, though obviously angiography will bring that in as well. So I'm not a fan of it. The other is that the children who, if they are getting surgery, it's very important to know where and what the blood supply looks like on the scalp. And I find that hard to appreciate on most MR studies. Even with MRA, with surface coils, they're called, try to look for surface vessels, they can be hard to see. And I do find them exquisitely helpful in the operating room. So I do like angiography. The rap against angiography, I think, really comes from the need for sedation for many of these children. These children live in a carbon dioxide rich environment, essentially. They breathe a little less, and that builds up the CO2 in the body, which actually helps dilate their blood supply. That is not the normal thing we would see in the OR under anesthesia or in the angiogram suite under anesthesia. We tend to hyperventilate a bit. That's just a standard way to do things. But hyperventilation actually causes vasoconstriction, which means we're taking a brain that's already starving for oxygen and we're restricting blood flow, and which that means we can cause strokes. So I think people have shied away, and I understand why, from angiography as an undue risk to the individual. But I think under the right circumstances, with careful anesthesia, you can still do safe angiography. And I just think that there's more information to be gleaned. I do think that's changing, and it may be, in fact, at some point we stop doing formal angiography, but I do think we may lose a little information. This is the angiographic appearance of somebody with bilateral disease. And you can see that both left and right, essentially all you see are blood supply coming up, that's that quote puff of smoke in the midline on the patient's right, our left, and vice versa, our right, patient's left. And essentially no flow. This is the carotid artery. There's almost no flow through it. And you could also see the backflow into the external circulation and some scalp vessels. But this is someone who has severe stenosis bilaterally. They may, interestingly, have very little symptoms at this point, or they may have profound strokes. You really can't tell by the films. So the treatment is not as necessarily bleak as I may have already started to make it sound like. The treatment is actually phenomenal. It is one of the best success stories we have in pediatric neurosurgery, without a doubt. Medical treatment, I think, is insufficient for the vast majority. There may be some benefit for medical treatment once you've done surgery. We may get into this in the QA session at the end. I'm not entirely convinced that aspirin is needed or beneficial after surgery. I think a lot of centers use it. Most of the children I've treated have never gone on aspirin, and they have not developed problems. Those that are symptomatic, I think, may do better with something like Plavix, and I do have 1 or 2 children on it, but still, vast majority are on no medication and doing well. Surgery is the hallmark treatment, and it's gone through a real interesting history, which I won't bore everybody on. I do have I think the next slide talks a little bit about it, but nowadays, it really comes down to 2 main procedures, and they really do divide at adult versus pediatric. Most adult centers, most adult neurosurgeons rely on what's called direct bypass surgery, or STA, MCA, a lot of people call it STAMPCA, or ECIC bypass. So STA is superficial temporal artery to middle cerebral artery. ECIC just means external circulation or external carotid to internal circulation or internal carotid. It's a direct bypass. It requires temporarily stopping blood flow to the brain on the affected side and tying in an artery directly to a branch of the middle cerebral artery, usually, to give immediate blood flow. When it works, it gives instant blood flow, which is wonderful, but it does require completely stopping blood flow to that vessel while you're doing that surgery from 30 to 60 minutes. I'm concerned in pediatrics. I think that increases the risk of stroke. And in addition, in pediatrics, we're dealing with much smaller caliber vessels, and even a beautiful appearing anastomosis may clot off hours or days after you've done it. So I worry about that. I think most pediatric neurosurgeons have had that concern. Many iterations have gone on over the years to do what's now an indirect bypass, which is now a onlay graft of the same artery, usually the superficial temporal artery, applied to the surface of the brain. And the blood-starved or oxygen-starved brain will basically parasitize like a sponge the vessel. The vessel will grow in caliber to feed the brain, and you can get beautiful, exuberant blood flow to the brain within weeks to months. I'll say months, but you can even start to see symptoms get better within weeks, it seems, through that technique. When that vessel is not available or not usable for some reason, I have found that just making holes in the skull and opening up the membrane that covers it, the dura, will allow the scalp to still be parasitized by that oxygen-starved brain and do just as well in operation. It's not as aesthetically pleasing to the neurosurgeon, but it works beautifully as well. Some surgeons take the chewing muscle, the temporalis muscle, which is in that area, which is literally moved out of the way to do the surgery, and apply the muscle directly to the surface of the brain. I've not done that. I think it is oxygen rich. It's a fabulous supply, but I worry at least about putting the muscle directly on the surface of the brain. People have had excellent results. The first operations, which go back several decades, were really quite innovative, and they took the omentum from the belly, which is attached to the small intestines, and they pedicled it. They basically left it on a blood supply and tunneled it under the skin through multiple incisions up and placed it on the surface of the brain. Again, oxygen rich, but a very quirky operation. I don't think anyone's done that for decades, but it did work. And then finally, something I think that it really is not used much, which is called sympathectomy, which is basically try to affect the innervation, essentially, that allows the blood vessels to spontaneously dilate and get better blood supply. Most people don't use that. I never have tried it. The SDA-MCA anastomosis we talked about, again, readily used in adults, I think rarely used in children, just because the caliber of the vessel is so small and that you have to at least transiently close the vessel, and it just makes me uncomfortable. I'm not dealing with hemorrhage. I'm dealing with children who have ischemia at baseline, and now I'm going to temporarily occlude a vessel which is already in an ischemic area and worry that I cause a permanent stroke. So I don't do it for that reason, but I do think for adults, it's a reasonable option. So what has been termed EDAS, and I think now more commonly termed pilocytangiosis, they're all variations on a theme, is to take this vessel from the scalp and just apply it to the brain's surface. Its benefit is that, number one, it's not a crucial artery. It supplies the scalp, which has an enormous redundancy in blood supply. So if the vessel is injured as you try to utilize it, there's no harm to the scalp, and there are other solutions. But the key thing is you cannot ligate it. Ligate means you can't cut it. It's got to keep flowing. If you cut it, it will not be able to do its job. It'll just thrombose off or close up. So it has to be in continuity, and you'll see how I do that in the pictures of the surgery. It is definitely technically easier than the STA-MCA anastomosis. It's in its basic nature a simple operation. It doesn't challenge the neurosurgeon other than harvesting the blood vessel, but you don't need to work with microscopic suture and apply the end of the artery to the side of another artery. And it can be, though I generally don't do this any longer, supplemented with just making extra holes in the skull bone. I have a beautiful picture of how that works, but I generally don't do that any longer. I haven't found it necessarily something we have to do. Multiple burr holes, as I say, it is a operation I'll use if I don't think the caliber or the location of the superficial temporal artery is adequate. It's also a bailout during the surgery. If I find the artery just can't be harvested safely, or if I lose it for some reason technically, I can do burr holes at the exact same time. I don't have to abort the operation. It works, in my experience, as well and as quick and as safe. But again, aesthetically, I don't think it's pleasing, so it's not my go-to operation, but I have no doubt it works fine, and I have no problems offering it, and I have not had complications using it. The biggest issues to me, and this is what makes my anesthesiologist's blood curdle when I say it, is that the risk of surgery is not the surgery, it's the anesthesia. Of course, they quickly say, no, we're not operating to give anesthesia. You're operating on the brain and we're supporting you. So they are correct. They're not routinely offering anesthesia to children or adults with Moyamoya. They're only doing it because we're operating. But that said, The surgical issues really should not be surgical. They should be the environment you put the patient in while you're operating. Most neurosurgeons have learned to operate with hyperventilation and diuretics, things that allow the brain to be a little bit more relaxed, not to pulse as frequently. And those are the exact opposite things to do for a person who has Moyamoya. Moyamoya needs a PCO2, a CO2 environment greater than the normal. And they provide it themselves perfectly fine. The child breathes a little slower, and that drives their CO2 up a little bit higher than normal. They don't even know they're doing it. Their brain tells their heart, pump less, tells their blood vessels, dilate a little, and it's a perfect environment. It gets into trouble when we tinker. We tinker when we're under general anesthesia, and we control all those things for them. And in the beginning of my career, we had a few children who had strokes after surgery, and it became apparent those strokes were due to the fact we were not able to regulate their blood supply to the brain adequately. We didn't know what was going on. Very early in my career, we switched to using EEG, and we do it once the child's asleep. We put on bilateral leads, and that has become the hallmark of management. With that, we've not had a stroke or an ischemic event in probably 20 years. The EEG tells us in real time if we're starting to cut down on blood supply to the brain, and we can immediately adjust our parameters. We can increase the blood pressure. We can slow up the ventilation a little. We can make adjustments. And if we don't get the adequate response, we stop the operation. That has not happened. We've been able to do these things in real time and continue through it to surgery, and it's worked out beautifully. We don't generally use anticonvulsant therapy unless someone's having seizures, in which case we'll maintain it. But since we're not going into the brain, we haven't found a need to do that. The risk of the operation is greater in children and in adults who are actively having TIAs. As a general rule, we will try to wait at least 4, if not 6 weeks or longer before we operate. If we operate during a storm of events, we probably are at much higher risk. The question always comes up, but what if you do, if every 2 weeks you're having TIAs, you can't get there, then we have to operate. And we do our best to maintain these parameters in a fashion that doesn't put the person at risk. The EDAS procedure usually starts not really here, but it's the angiogram we look at, or if you have very good quality CTA or MRA, you look at the external carotid circulation in a lateral side of the head projection to figure out where the vessel is. We then use a Doppler, which is a simple tool to look for a pulse on the scalp and map the pulse. The operation takes place where the vessel is. You can't move the vessel to the problem. You have to use the vessel where it's sitting exactly. You can't move it or you'll torque the vessel. So you map out the length of the vessel, which is roughly about 4 inches of vessel. And it starts just about above the, we call the zygoma, just above the front of the pinna of the ear, the side of the ear where my hairline used to start, and follow it up over the scalp, not to midline, but usually just around the crest of the skull. That'll usually give you about, we say 10 centimeters or 4 inches. The artery is isolated, again, not ligated. You need pulsation of blood going through it to make it work. So you make an incision directly over the artery, you find the artery, you separate the artery, not cleanly. You want actually a little bit of tissue on the artery. That tissue has a lot of good adventitial layer, it's called, and that is applied to the surface of the brain. It's probably that and not the artery itself that sprouts the vessels quickly, though the artery obviously feeds those tiny vessels. We then will make what's called a craniotomy, an opening in the skull that's temporary. We will move a plug of bone, basically the shape of a football you'll see, away with protection to that vessel, open up the coverings of the brain, and then suture the vessel down to the surface of the brain. That part is done under the microscope. And then we put the bone back, and you'll see there's 2 holes in the bone, a hole that the vessel goes in and a hole that that same vessel comes out. And there's enough relaxation in the vessel so it's not under any stretch when we do that. And then we close up the scalp. So I skipped the intraoperative photo of the Doppler. I didn't know if families wanted to see a picture of a baby or a child's head shaved, so I skipped it, but that would have been the step. Here is a picture of, let me try not to move the mouse too much. This is the artery running along the surface of the skull. This is a retractor holding the scalp open. Here we have about 8 centimeters of vessel exposed. The artery is not this entire width. The artery is just this glistening sort of tubular structure that's probably no more than a millimeter, as you can see on this picture. The rest of it is the adventitial cuff that we're going to use to our benefit. The next step is to open up the skull. And here I have drilled a hole at the entry point, and I've drilled a hole at the exit point. And I've drilled a line. This is like a lathe or a jigsaw, I guess, surgical equivalent of jigsaw, where I've made cuts to lift this bone out. We can only make the bone opening so big. If I make it too big, well, it may expose my brain. It'll also make it harder to lift out without damaging the arteries. So we have to play off what's beneficial. These tiny dots are holes in the bone that are going to be used at the end to suture the bone back in place. You can use titanium. A lot of people use titanium normally to put the bone back. I don't. I worry that the titanium gives off some artifact that makes the imaging harder to evaluate. So this is the one case where I'll use sutures. You can also use plating systems that dissolve. I just won't use titanium as a general rule. This next slide is the surgeon's view just before the microscope is brought into view. There are stitches in the membranes opening up what's called the dura or meninges. And these are just stay sutures to hold everything open. And this is the surface of the brain and the vessel just laying on top of it. The microscope will be brought in to cut away this glistening surface. That's we call the arachnoid. It's like a waterproof but permeable somewhat membrane, but it does, sorry, let's go back. It does slow up the creation of these new blood vessels. So I tend to cut away some of it and then suture the vessel down with sutures that you cannot see unless you're using the microscope, things that ophthalmology would also use. And that holds the vessel down. And then once that's done, you simply put the dura back in place, put the bone back down, suture it down, and close the scalp. And that's the operation. It's not a brain operation per se. We work on the surface of the brain. We work on the arachnoid of the brain. We don't go into the brain. So maybe it's disingenuous to say it's not a brain operation. Obviously, we're staring at the brain. We're working on top of it, but we don't go in. It's a simple augmentation of a surface artery to the surface of the brain. This is, I don't know, probably 2 or 3 years out from surgery. This is a lateral projection of the angiogram. Same patient, just different time, either 1 second, 2 or 3 seconds into this. This is the external circulation. We're not injecting the internal carotid artery, only external. And you can start to get a hint that this external carotid artery is blossoming out vessels that normally wouldn't be fed by it. And a second or two later, you see this really rich blood flow all over this area. None of this is going to the scalp. That's all going not just to the surface of the brain, but deep into the brain. And it's supplying the brain that was ischemic or starved before. I think the next picture shows it even better. This is now we call the AP or anterior posterior projection. We're looking directly at the skull and injecting. And on the left projection, you can see blood coming up through the external circulation. And if you look a few seconds later, all of this is blood now in the brain. All of this is feeding the middle cerebral artery distribution, which is what feeds the motor and sensory cortex to the brain. This is a fabulous post-operative result. This next picture is a CTA, and I generally don't get a lot of CTAs because there is radiation, but this was a case where I did need to get it, and they reconstructed it for me. And this is the best example I've ever seen, and it shows a couple of things. Number one, this is the superficial temporal artery as it comes up. This is the scalp blood vessel. It branches, as it normally does, into an anterior and a posterior branch. The normal caliber is probably double, triple, quadruple on the posterior portion of the artery. And you can see how much bigger that caliber is compared to the anterior branch. Why? Because it's feeding the brain. You can see where it is going through an opening in the skull, down to the surface of the brain, traveling 2-3 inches, then coming up out the other hole in the skull and going on its way to continue to supply the scalp. So there's wonderful blood supply still going to the scalp, not that you need it, but the artery is clearly feeding the surface of the brain. When I used to put holes in the skull called burr holes to augment, it was random where they went. This is just one of those, luck sort of things where it happened to be right next to this artery, and that artery is now feeding through that opening in the bone. That's spontaneous. I did not put that vessel there. It just so happened that the scalp vessel was close enough to the burr hole that it sprouted new blood supply. So again, wonderful picture. This is the operation that I will do if I need to. It's the same incision, same approach, but I've just opened up the skull in 8, 7, 10, really doesn't matter, roughly 18 millimeters or greater bone openings. And I've opened up the dura and stitched it back. Those tiny little black lines are stitches to hold the dura open. The scalp goes back, and just from that last picture you saw, the scalp can now supply blood to all of those areas of the brain surface very quickly and readily, and it does work, as I say, beautifully. Prognosis is excellent. I think most people will quote 90-95% 10-year symptom-free, progression-free survival. And the only children I've had ischemia in have actually probably been the sickle cell group. But if you control their sickle cell, that usually takes care of that group. And I've not had to manage people for recurrent disease on the side of surgery. There have been children who've progressed from unilateral to bilateral, and I have had to operate, and again, with good success. I have had, I think, 2 children who have developed Moyamoya at 4 different sites in the brain, and actually have had 4 operations and still are functioning well decades later, now in their late 20s to early 30, and 1 or 2 who have had some very minor ischemia with good blood supply, who are on blood thinners such as Plavix and doing well. So I think it is a very treatable condition, and one that I think this should really not be a discussion. If a child has it and there are no other risk factors that could be managed, they should have treatment, because it is a very successful operation. This, I think, will be a time for chat, but even before that, in case people want to log off, this is what we call the shameless promotion. And I have 2 slides to show our group of really, just awesome technicians, physicians, people. I think we'll bend over backwards. We'll, split a gut, as they say, to help take care of your children, your families. Available really 24/7. We've been blessed with being able to merge 2 phenomenal centers between Cornell and Columbia to this combined entity. We can treat at either institution. We cross cover really effortlessly. And so it doesn't really matter where you go, you'll get the same quality care. And we all are very happy working with that team. This, again, shameless slide shows our main campuses, but we have offices to really throughout the area, ever looking to expand. And we are happy to meet with anyone who would like to speak with us through these kind of chats, through other chats that we provide, emails, phone calls. Really, we're here to help. So with that, I will stop, and I hope we have plenty of time to take questions. And I guess won't stop the slides yet. If there's questions, let's see.
I don't see anything in the chat room. Can I ask you a question, Neil?
Yeah, please.
Can you hear me okay, Tatiana? Roseanne? The question I have for Dr. Feldstein is that there's an association with strokes or stroke-like symptoms induced by exercise in this disease. Can you make any recommendations as it relates to avoidance of exertional activity, exercise before and after treatment?
So before treatment, but it's a great question. So before treatment, I think the answer is anything that precipitates these events has to be stopped. I've seen it from singing in a choir. I've seen it from playing a wind instrument, running around in the playground. Anything that leads to hyperventilation could drive it. So they have to stop immediately. Most children usually can relate that they know they're precipitating it and will stop it. After surgery, once you have good blood supply, I think it's fine to resume those activities one at a time. You ease into it just to make sure you don't have symptoms. But interestingly, one of the bigger risk factors I saw, and I hope they're not online listening to me right now, maybe they are. I had a family very much into snorkeling, which seems like, why should that matter? But they wore a snorkel mask, which puts a lot of pressure over the takeoff of the superficial temporal artery. And the fear was that that would somehow cause ischemia. And we're like thinking hypothetically you shouldn't wear snorkel masks. That never came to be, and they were fine, but it was a consideration. And the other, I guess, would be very tight glasses. If they really pinch the scalp, maybe at least while the artery is developing would probably be something not to do, and to try to come up with glass frames that bow out a little past the zygoma, so the superficial temporal artery is not compressed. But other than that, I think it's probably fine. But yeah, if you're symptomatic pre-treatment, you need to stop all of those activities.
Thanks. Another question that comes up periodically is individuals with neurofibromatosis or sickle cell. If this is detected and the patient has had no ischemic symptoms, no stroke, no TIA-like symptoms, is an asymptomatic patient okay to follow?
So the answer is probably yes. The playing field has gotten easier for us in that we now have things such as MRI perfusion studies, and we can actually see perfusion to the brain. If perfusion is adequate, which it can certainly be, even with early occlusion, then there's probably no benefit to bypass surgery. We used to have to do much more complicated tests that were hard to achieve. We had difficulty getting them done, things called diamox suppression studies. So luckily we don't have to rely on them anymore. If you see evidence of perfusion failure, even if asymptomatic, I think you should have surgery. But if you don't have, you don't need to. I think the basis for that answer is this operation assumes that the blood vessels being placed in an oxygen-starved environment. And if it's not oxygen-starved, there's no reason the operation should work. The brain won't parasitize the vessel, and you'll lose it potentially. So I think you need the brain sending out, however it does, signals that generate this new vasculature that we don't normally have if we don't have that ischemic environment.
I don't know if you see the chat box open, Neil, but there is a question from the identifier is Mary Angelo. Does the disease run in families? If my husband had it, is there a concern regarding our children?
So probably is a slight risk for that. We do know, for instance, Asian populations, certain American Indian populations, we've seen it in. So I think there's probably a small risk. I've never had anyone in my practice where there's other family members, but I think it's reasonable since we have non-invasive studies like MR we can do to screen for it. It's a simple thing. It's probably a low level, but it's probably not zero.
I don't see anything else in the chat. There is a question by Dr. Balabang. Always a pleasure to see you. Thanks for joining. as to whether or not these are recorded for distribution for her residents in child neurology. Tatiana or Roseanne, I don't know if you can answer that. They can't hear me. Another question in the chat while we're waiting for that, Neil. Are the genetics of this disorder understood? Our daughter has NF1. It affects so many factors of her life. So will Moyamoya have another knock on the effect behind the brain blood flow?
Yeah.
So should patients with NF1 or sickle cell be screened, I guess is another way of answering this.
So the answer is yes, but probably coming at it from a different direction, which is, I think the NF Society, a lot of these, like tuberous sclerosis, and they're all sort of linked somehow, have recommendations built into how often screening tests should be done of the nervous system. MRs are not designed specifically to look for Moyamoya. They're to look for any problem that may develop in the nervous system. So it should be picked up. You wouldn't have to alert a neuroradiologist to look for Moyamoya. They would see it if the MRI is being done looking for any any NF related condition. So I would say you probably don't have to specifically ask that question. I would think at the minimum, probably 5 years would be a reasonable thing. I think currently for NF population, and you may be able to correct me, it's at least every 5 years to do non-invasive MRI imaging of the brain, not necessarily the spinal cord, but of the brain. So you would pick it up anyway. I would say the risk of developing of developing Moyamoya in NF1 is still exceedingly low. It's just that it's a known risk factor. And again, in my practice, it's been sickle cell more than NF that's led to the diagnosis and the need for treatment. So screening, probably the best thing would be MRI scan, especially if you don't need sedation. The sedation is always that booby trap potentially. If someone gets sedated for a study would never have otherwise been sedated, and that precipitates an event, there's a problem. It's sort of a catch-22. If you do a CT scan, you're doing radiation, which may affect the brain. You know, we worry about doing unnecessary CT scans. So I think if you need to be sedated, then there has to be I think a discussion with neurosurgeon and the anesthetist so we can come up with a happy way to get this done safely. I would not do an angiogram for making a diagnosis. That's too invasive. So it would have to be a protective type of MR being done.
And Neil, do you see the question above?
This is the 40-year-old?
Yes.
Okay.
While Neil is reading that question, I just want to remind everybody that posted in the chat box is the link to view any of these house call seminars, including today's, on YouTube. So if you visit the chat box, there is a link there that'll take you to YouTube where these are listed in perpetuity.
So I think this gets back to my the comment recently. I think if you're asymptomatic, then it's presumably because you've already developed your own collaterals somehow. And there are definitely people who develop their own collaterals, either internally or externally. Sometimes scalp vessels will grow through tiny openings in the bone and in the dura, it's called, to feed the blood vessels on the surface of the brain, and you'll have adequate supply and you won't need bypass. So even though you may not be able to see those vessels, they're there and they're supplying the brain and they're adequate. And I think if you have good perfusion, then the operation, at least the indirect, wouldn't work. And if you're telling me that presumably the angiogram or CTA or MRA showed insufficient STA vessel, that you're not a candidate, I wouldn't do an indirect or burr holes because you already have adequate supply right now. So I wouldn't take that risk if I were you.
Any other questions here?
I do know people are sometimes shy about asking questions. If you want to get back to the group, that's fine. We will answer them offline if we can help. As I say, this is our opportunity to reach out to you and let you know that we're available. And any of the four of us, I think, are quite interchangeable. We've all treated children and families with this condition. We're all happy to take those calls. So just please reach out to us and we'll get back to you. So now this gets to the curious answers. If somebody is completely asymptomatic, they could start participating in activities. If you're on a roller coaster and you're hyperventilating and you have not done anything else yet, could that precipitate problems? The answer, unfortunately, may be yes. So I think I would suggest you speak to your neurosurgeon, go with their guidance. They're the one you've trusted to get through surgery so far. I would like to know that somebody has reasonable collaterals before that. Maybe do an MRA. It's a simple test to do to see if I see evidence before allowing that. That's a little different than running in the park. You could stop running instantly. You can't stop the roller coaster if you're getting into trouble. So I would say defer to your neurosurgeon. I'd be a little cautious on that one.
I've always wished you could stop a roller coaster. Someone's asking about whether or not you offer telehealth visits on adults.
Well, I do. I generally refer them, at least on the Columbia side of things, to Dr. Sandra Connolly. He's done all the adult Moyamoya also for about 2.5 decades now. We used to work together and then we sort of separated. He treats all the adults, still primarily with indirect bypasses like I do, and with EEG, we do things the same way. So I would say probably through him, but if you have any difficulty reaching his office, then reach out to me and I'll help get you through to him. I won't speak for Dr. Swedane. He can answer that if they treat the adults on the Cornell side or if the adult neurosurgeons treat the adult Moyamoya.
Pretty much the same platform. We have a very busy adult neurovascular team who treats the disease as well. So if you're interested, just reach out to any of us through those connections, and we can certainly align you with our colleagues who treat this in adults.
And the interventional neuroradiologists are the same people. They treat both the children and the adults.
Good.
But I'm happy to help make the connection for you if you need it.
All right. Fantastic, Dr. Feldstein. Thank you.
Should we continue with the last question? Hydration is key. Staying out of the heat and hot days can be quite key. As I've said earlier, I'm not really a big fan of aspirin. If you've learned that you do have minor symptoms, tingling, headaches, and it seems to respond to aspirin, that's fine. I generally don't have my patients on aspirin. For adults, I do worry about being on aspirin. They do present more with hemorrhage than with stroke, and presenting with hemorrhage on aspirin is probably problematic. So I don't like to do it. In kids, I think it's a little safer.
We're good.
Okay, well, thank you, everyone. I appreciate you're watching me at either dinner time or work time, and I hope you actually don't need my help. I hope you're doing well.
Thanks.
Bye.
Thank you. Good night, everyone.